So the way I like to think about metabolic therapies is we don't want to necessarily compete with traditional therapies. We want to add in a fourth branch of oncology. So right now we have surgery, we have radiation oncology, we have medical oncology, which is drugs. What metabolic oncology would be a way to prepare the body by weakening cancer cells and making healthy cells more robust so traditional oncology can work better.
Facing a cancer diagnosis can feel like navigating uncharted waters. You're searching for answers, for hope, for time. Welcome to the Heal Navigator podcast, where we explore integrative and alternative cancer treatments and therapies from around the world. I'm your host, Peyton Thorne, the head of patient care here at Heal Navigator. The Heal Navigator podcast is here to provide you with the options, insight, and the hope you need now.
Today, we're exploring the potential of metabolic therapies and repurposed drugs, and I'm thrilled to be talking with Travis Christofferson, author and advocate for metabolic approaches to cancer. Hello, Travis. How are you doing today?
I'm doing great. So happy to be here. Thanks, Peyton.
Our listeners can better understand who you are, a little bit about your book, where they can find that at, because you have so much knowledge, Travis.
Well, thank you. Yeah, humbly. Yeah. So I have 3 books. The first one was Tripping Over the Truth on the metabolic theory of cancer, which is what, we touched on. It's about goes back, it starts with Otto Warburg and him proposing the theory and, just the historical narrative of where cancer is gone today and these competing theories. The second book I wrote was Curable, which didn't sell nearly as well as my other 2, but it was actually my favorite. It was about the inefficiencies in the healthcare system. Why the simple question of we spend more than every developed country on the planet on healthcare and have by far the worst outcomes, the worst life expectancy. It's not even close. So we're doing something very, very wrong. The third book was called Ketones, which is about the ketogenic diet and this question of what is the optimal human metabolism? Are we carbohydrate burners? Are we divorced ourselves from the most optimal version of metabolism, which is completely different? If you eat a low carb diet and you're active, then you go into this state called ketosis. So it just explores that. Metabolic therapies can put people into dramatic remissions. So that's interests me too right now. But that's it. Other than that, I live a pretty basic and boring life.
It's not basic and boring. You're a researcher. I mean, what got you so interested in cancer and metabolic? Like, do you have like a driving story for that? Or is it something you just stumbled upon and you really fell in love with?
Well, I've always been interested in health. And that's why I got, a biochemistry degree and my master's was in immobilized enzyme. I just love biochemistry. And so I've always been interested in that. And cancer's always been this, loomed the largest as the problem in biology. We really didn't even know now we're questioning the mechanism of what starts it, like we just discussed. So it was just intellectually, it was a big problem. And I was doing my master's thesis and they allowed me to do an independent study. And that's when I found Tom Seyfried's book. And that kind of set me off on that trajectory. It was just really intellectually, as a biochemist and, appreciating how a cell operates. It was just interesting intellectually.
Oh, yeah. Thank you for joining us and covering this topic. I understand you have so much information. You partner also with Dr. Meakin and applying these types of therapies to patients worldwide, really. Also, you have done a lot of research yourself and a lot of upcoming projects you're working on. So I can't wait to dive in and share all of your knowledge.
Thank you. Yeah, happy to do so.
For our listeners, many of whom are actively undergoing treatment, can you explain in simple terms what metabolic therapies are and how they differ from standard of care treatment?
When we say metabolic therapies, I think it gets confusing. When we talk about metabolism, what we're referring to is all of the chemical reactions that occur in the cell. And there's thousands of these, but what we're typically referring to is energy producing metabolism. So when we look at cancer cells, and this has been known since the 1920s, that they have a very distinctive metabolism. They've shifted towards a less efficient method of energy generation than healthy cells, and they're stuck doing that. They don't have a lot of options. So this was first discovered by a German scientist named Otto Warburg, where he noticed that cancer cells weren't generating energy with oxygen the way healthy cells do. They use a process called fermentation, which requires blood glucose. And then when DNA was discovered and it was thought that cancer was a genetic disease, that it was caused by mutations within cancer cells, everyone really forgot about metabolism. It came the old boring stuff. It was so much more interesting to look at the code, at the DNA, at the mutations. Now we realize that it's a very important therapeutic target. And the first scientist to really dive into that was Tom Seyfried. And many of your listeners probably know who he is. If you do an internet search on anything cancer, he's probably going to pop up. And the sort of the low-hanging fruit of exploiting this therapeutic differential is restricting blood glucose. And the way to do that is through low carbohydrate or ketogenic diets. And what those do is they shift the body's metabolism towards burning fat and not relying as much on blood glucose and insulin. So, and by the way, cancer cells have 10 times the number of insulin receptors than healthy cells. So they are primed to want blood glucose. So that's kind of the low-hanging fruit of what we call metabolic therapy. This idea has been around, I think, since about 2012. And, when I wrote my first book, 2014, about metabolic theory of cancer, nobody was really thinking about it. Now, fast forward to today, and my foundation is helping to sponsor a huge clinical trial that's done at 5 centers. Cedars-Sinai is one of them. So credible places, where the neuro-oncologists are taking this question seriously. Can a dietary therapy influence outcomes in cancer? So it's come a long way. And obviously there's repurposed drugs. There's all kinds of things that dovetail with that idea.
So how does the metabolic approach to cancer treatment address the root cause of cancer?
That's a great question, right? So the settled science, or what the dogmatic view on cancer, is that it's a genetic disease caused by mutations to existing DNA, to genes. That was the what we called settled science in 1976. Two guys won a Nobel Prize for really cementing the somatic mutation theory of cancer. Since then, lots of things have happened. The Human Genome Project, sequencing DNA got dirt cheap. That sparked the Cancer Genome Atlas Project to sequence the genomes of all the different types of cancer. So finally, we would see what these mutations look like. And it was thought there would be a tidy sequence of genes, of mutations that defined each type of cancer. And that's not what we found. What we found was a lot of chaos. And so that opened the void for guys like Tom Seyfried and others to step in and propose new ideas on what the origin of cancer is. And he proposed a metabolic origin where there's damage to these cellular organelles called mitochondria that generate energy. That precipitates a cascade of events leading to epigenetic changes, the changing of gene expression. So you turn the dials of all these oncogenes up, turn the dials of all these tumor suppressor genes down, and no mutations are required. It's just an epigenetic switch, and this causes cancer, right? So those are two different pictures of what cancer is. So the way I like to think about metabolic therapies is we don't want to necessarily compete with traditional therapies. We want to add in a fourth branch of oncology. So right now we have surgery, we have radiation oncology, we have medical oncology, which is drugs. What metabolic oncology would be a way to prepare the body by weakening cancer cells and making healthy cells more robust, so traditional oncology can work better, and perhaps even use lower doses of things like chemotherapy to get even a greater effect with less toxicity. So I think that's the way that I like to frame it. Is it's not a competition. You don't choose one or the other. It's a addition of a new idea.
Yeah, they can all work synergetically with one another and potentially enhance the effects of treatment that are currently being offered now, So why aren't people's doctors currently recommending these types? For instance, I have patients that I talk to all the time that have glioblastoma, And I mentioned to them like, hey, there's a lot of research supporting mebendazole, for instance, and ketogenic diet. Go ahead and mention it to your doctor and see if they're on board with it. Most come back and say no. Why do you think that's the case?
Well, this is the regulatory environment that we live in, right? And these are the things that excite me. Is when you have these incredibly potential treatments that are extremely low risk, that are forgotten for bad reasons, for reasons that this is the way the system is structured. And so when you look at the system, it's very stark. You get a treatment has to go through an approved process, a randomized clinical trial. The FDA analyzes those results, and then they give it the stamp of approval or not. That's the process. It costs billions of dollars. It moves excruciatingly slow. And then that's the doctor's playbook. That's their toolbox. So for glioblastoma, for example, they have temozolomide, which is a very old drug. They have radiation. They have surgery. Sometimes some off-label drugs get used, like Avast and things like that. So it's very limited, and there hasn't been a change in the treatment for glioblastoma for a long time. They don't know enough according to that regulatory environment, for them to recommend a ketogenic diet. They almost always say, well, there's not enough data. And that, according to that, that structure, that they're right. There is not a gold standard clinical trial to point to. That's obviously what we're trying to change right now with this trial. But so when you look at it from that lens, you get it. But then there is a lot of data on ketogenic diets and cancer, from mechanistic data to mouse data to human trials. And for example, the one Cedars-Sinai that's going on now, the reason they did it is because the PI, Jethro Hu, the neuro-oncologist, he had a lot of patients coming in on the diet. And he just made the simple observation that they seemed to be doing better. Their quality of life was better. They weren't having seizures. They were responding to the chemotherapy better. So he observed this, right, with his own eyes. So you ask that question. You say, here's what we know about it. There's safety data. We know it's not going to affect the outcome of the standard of care. So it's an extremely low risk. So in the context of a terminal illness, and the risk reward is there, right? Why wouldn't you try it? So, and there are doctors out there, some don't say categorically don't do it. There are those that know about it and even encourage it. It just depends on the doctor. You're probably right. The vast majority would say either don't do it or why bother. So yeah, it's a different calculus, and patients have that calculus. They have the risk reward calculus, but a lot of oncologists, they're busy. They don't have time. And they're just doing, within the structure of the medical system, they're just following that toolbox, that approved toolbox that they have.
Yeah, I like to relate it to like a flow chart, essentially, that they're following. It's like, okay, this is your diagnosis. This is where you're at. This is where you will be. And then they don't really veer from that path. Could you give some examples of different repurposed medications and how they're being used for cancer treatment?
Yeah. So repurposing is another one of those things that gets me excited because, again, it's lost opportunity because of the regulatory structure. And so most people know when a drug gets approved for a certain indication, it's on patent for 10, 20 years, and then it goes off patent and it becomes a generic drug. So it becomes much cheaper. So what happens often is let's just use metformin example. It gets approval for type 2 diabetes. People start taking it, and metformin is one of the most widely prescribed drugs in the world. So then decades pass. Now researchers can look back at thousands, tens of thousands of people that have been on this medication over long periods of time. And what happens? What happens when they get cancer? What happens when they get heart disease? What happens? What you can measure their rate of getting cancer. So all these interesting questions about the drug, you're able to answer over time. Now you reach the patent expiration. So now let's say with metformin, you notice that, oh, wow, type 2 diabetics on metformin get much less types of this cancer. When they do get this cancer, they tend to have a much better prognosis. Now it's a generic drug. There's zero incentive for anybody to win the indication for cancer because they don't have patent protection, right? So it falls into this financial purgatory that you've lost the potential of what could be a potentially wonderful cancer drug. So that's the concept behind drug repurposing. And what's interesting about drugs like metformins is they, on average, affect 12 different molecularly relevant pathways in the cell. So they're going to be good. You're going to find other indications for these drugs when they've been in the clinic for a long time, and you can look back and measure retrospectively their activity. So yeah, you have drugs like metformin for cancer because it's a drug that lowers blood glucose. So we just talked about, why you'd want to do that in a metabolic therapy. It does lots of other things. It inhibits other oncogenes, things like that. Drug repurposing, there's so much potential. There's lipophilic statins are another very exciting one. Mebendazole, you mentioned Fabendol. You go down and down the list, and they're just, it's an interesting time with drug repurposing. And I know you talked to a colleague of mine, Padman, about Astron health and this concept of synthetic lethality. When you couple that to drug repurposing, I'm really excited about what we can do with that. There's just some really fascinating examples that we found.
Yeah, let's just go ahead and dive into Astron. Tell me how you know them, how it's being used for repurposed medication.
Yeah. So Pat and I have worked together for a long time. He's an absolutely wonderful human being, incredibly smart. So him and I have always wanted to work together. And then we were starting to do an online sort of clinical idea with because now genomic tests are so cheap, so you can find out so much information about the type of cancer and how to target it personally with patients. So it was around that. And then we just stumbled on this idea of synthetic lethality together. And it was just a light bulb moment for us because it's a confluence of three things happening. One is these genomic tests have gotten very cheap, and the majority of patients now probably the majority get them and insurance covers them. So you get a report of all the mutations within each patient's cancer type. The second thing was with this concept of synthetic lethality, which is a pretty easy concept to understand in cancer, where when a patient does have a mutation in a specific gene, what a synthetically lethal gene pair is so that gene has become dysfunctional. The cell now has to rely on another gene. So this is a synthetically lethal partnership. That gene compensates for the broken gene so the cell remains viable. So the healthy cell doesn't have that mutation. So in the cancer cell, if you inhibit the second gene in that synthetically lethal pair, you can kill the cell without damaging healthy tissue. So that's the concept behind synthetic lethality. The third confluence thing that happened, and now you couple that to drug repurposing, and there's these massive databases now because of CRISPR showing you these synthetically lethal relationships. You become agnostic about the drugs of choice, and you can couple this to drug repurposing. It just broadens the scope of these potential therapies by a huge amount. So we have had the most, creatively satisfying time just looking what we found in these drug databases with how you can help patients. For example, one we found, there's a strong synthetically lethal relationship between ER positive breast cancer and a gene called PIK3CA, which is a metabolically acting oncogene. So when both of those genes are inhibited, it creates a synthetically lethal relationship and the cancer cell dies. So we found that relationship, and then we go, okay, what can you inhibit PIK3CA with? And you go through a drug database and you find caffeine is an extraordinarily good inhibitor of PIK3CA. So we go, okay, that's interesting. I wonder if there's any data on women with ER breast cancer, positive breast cancer, on estrogen inhibitor and coffee consumption or caffeine intake, whatever. So we searched and we found a study in Sweden with 1,000 women, and it stratified them. So these women are ER positive, they're on tamoxifen. It stratified them by coffee consumption from 0 to low, which is 1 to 2 cups, to high, which is over 2 cups a day. And there was just a beautiful dose response curve with overall survival and recurrence, to where it was cut recurrence in half. The women that had high consumption of caffeine, coffee, that were on tamoxifen, their reoccurrence was cut in half. That's absolutely remarkable. So we find these just incredible relationships like that with supplements, natural compounds and all kinds of repurposable drugs. And then we're able to give cancer patients these personalized protocols that we think may be, the best options for them.
Wow, that sounds amazing and groundbreaking. There are some programs that were out there where they were only using, say, 4 cocktails of medications. And this really broadens that scope to each person, their specific genomics and that pathway for them. So very
And
exciting.
think of when you dive into it as a patient level too, and you start researching, you see that there's hundreds of supplements with anti-cancer activity and so many repurposable drugs. Which one should I take?
Yeah.
I don't. This is a way to narrow that down to a list that's manageable, that we think is going to potentially have the most efficacy. Yeah, so I think it relieves a lot of anxiety as well.
Yeah, I hear it all the time. People, they're wanting to know, like, how is this program tailored to me specifically? And I do like go into like the different labs he does and how it shows different metabolic pathways that could potentially be inhibited through medications and supplements, but this really takes it to the next level. So I'm happy to see you guys offering this for patients.
Yeah, we're excited about it. It's good. And we just talked about if cancer is a metabolic disease, that means that there's one change and there's ubiquitous. Everyone's got these things going on that are potentially targetable. And that was kind of the idea of, well, what certain drugs can you target every type of cancer with? Metformin potentially being one where, since everybody with cancer has got that metabolic driver, you can lower blood glucose. You could do like an Astron personalized protocol and a ketogenic diet. There's good evidence that those type of things will help.
Yeah, they all work synergetically with one another. So let's kind of dive into a very hot topic, Fabendazole. Everyone knows about it now. Everyone's heard of Joe Tippen's story. It's all over social media. It was dropped on a few podcasts recently. Can you explain the potential benefits of Fabendazole for cancer patients? And what does current research say, or maybe some new research that might be emerging?
Those drugs, the azoles, right? There's a family of them. Mebendazole is one, Fabendazole is one. There's others, deworming drugs, but so mebendazole and Fabendazole only differ by, I think it's only 1 or 2 atoms, so they're structurally almost identical. What we know about mebendazole than Fabendazole, right? Joe Tibbins, that's an N of 1. We don't know if he would have responded to whatever protocol he was doing without Fabendazole, or if mebendazole was in place of it, if he responded the same. There's a lot of questions we don't know. But if it was me, I would lean towards mebendazole just simply because there's more data on the anti-cancer. There's actually a phase 1 study at Johns Hopkins on brain cancer with mebendazole. And I think it was, the data was good enough, they're going to a phase 2. So if I was going to guess, I would guess the activity is almost identical. But again, we don't know. Fabendazole may be a better drug than mebendazole. I have to ask you, Peyton, is it easier to get Fabendazole? Is it cheaper? Is there a reason why people are leaning towards that?
From my understanding, people hear about it more, to be honest.
They hear about it.
Yeah, they have the understanding that Fabendazole is a prescription. So when they come to me, they really don't know much versus, one or the other. They just hear about it more. They see it. People are recommending it more often. And I do think it's because of Joe Tippen's story, to be honest. It's been highlighted. And oftentimes expectations of using it is a little, they don't understand like the mechanic properties of how it works. So whenever I drop that, like it does provide like a mild chemo effect on the body on like a cellular level. They're like, what? They don't understand, or they have some people that think that if you take it for 2 weeks, your cancer is going to be completely gone. So there's a lot of education that needs to be supported in the use of Fabendazole specifically. But I do think that just because Fabendazole has more of a hype to it than mebendazole.
I have an interesting story I think you'll appreciate.
Oh.
So we started Care Oncology, and one of the first patients, right, we had a little clinic before we went to telemedicine. And so this guy came in, and he was from a ranch. I was in South Dakota, and he was from a ranch. So he came in, Wrangler jeans and cowboy boots. And I think he had, I want to say, a low grade brain cancer. So he went to he had a horse vet, and the horse vet told him to start taking Fabendazole because he noticed whenever one of his animals got cancer and was on Fabendazole, it seemed to cure it. And so his horse vet gave him Fabendazole, and I was just amazed. This is far before Joe Tibbins or any of the Fabendazole hype. And it's funny when you go back in medicine, a lot of the sort of innovations that oh, wow, that works. Vets had been doing it for a long time. Like one of the most interesting ones is fecal transplants. Shocking. A fecal transplant's a 98% cure for C. diff, which is a horrible, horrible intestinal disease. And we'd been using antibiotics. They work some of the time, but not all the time. And a fecal transplant's a cure. And vets have been doing that forever. So I thought that story was so interesting that, and I think that patient, if I remember well, I think he did really well. He just stayed on the Fabendazole, and we added in some more things, but I thought that was an interesting story.
It's very fun. I mean, I have heard actually similar stories of people, their vets recommending it. Yeah, I think the hype of Fabendazole versus Mebendazole, I mean, I think it's just, you just hear the Fabendazole more often. And not only are they asking like how to resource Fabendazole, but once you mention Mebendazole, they're like, okay, it's a prescription. So how am I going to get that? My doctor's not going to write it. And then you have to talk about, okay, well, for instance, Dr. Meakin can write prescriptions, or some people, if they're online, then they see that they can resource it from Indian-based pharmacies or whatever the case may be. So, yeah.
Yeah, and it's not, it's a little bit of a tricky drug to where there's 3 what we call polycrystalline forms of mebendazole, A, B, and C. And C has shown itself to be the most least toxic and the most efficacious. And so when I know Dr. Meakin, when he sources it, he makes sure that the provider, it's almost exclusively, this polyform C, which is important because if it sits in a vat under, temperature for too long, it can start converting to the A and B form. So it's just another level of quality control. I can't speak to the, the pharmaceutical on the veterinarian side. I would imagine it's okay, but I just don't know enough about it.
Yeah, that's a good thing to cover, though, because I wasn't aware of the differences as well. But I do know he works with compounding pharmacies, so that makes sense as to making sure it's fresh and a good quality product.
Yeah.
So how could patients discuss this option of using repurposed medications with their oncologist? Say that they work with Dr. Meakin, and then even they take it a step further with Astron Health. Are you seeing that doctors are willing to implement these, be confident enough to do so?
It's 100%, doctor to doctor basis. I've seen, I've witnessed this personally to where I've presented repurposed drugs in a room with a lot of oncologists, where one attacks the concept, and the one in the corner says, I use repurposed drugs to prevent recurrence. So it's all over the map, and it is completely legal for them to do repurposing, because it's the FDA, the way that the regulation is written is it just has to have scientific validity. They are going out a little bit on the limb because it doesn't have FDA approval, liability wise. But so I've seen everything. I've seen doctors completely almost get angry when you bring it up, or heard of them doing that. And I've seen, the oncologists that are prescribing repurposed drugs too. I think somebody that's got the expertise like Chuck, Dr. Meakin, who's been doing this for a long time, I like to consider them your metabolic adjunctive oncologist, and then you can, merge that with whatever traditional therapies you're doing. And they will look at the traditional therapies and make sure that what you're doing adjunctively with repurposing drugs is safe, right? So you get that layer of safety when you do it.
That was actually going to be my next question, is how can patients ensure that there won't be any interactions with implementing these types of treatment alongside what they're currently doing?
Yeah, that's the way. Yeah, these guys, those 2 that I mentioned have been doing this for a long time, and they do stuff. They have this clinical knowledge that unless you have the experience, they have that level of doing this for decades, and they know when they can get away with what they can get away with, what they can't. Yeah, you can't replace that kind of just experience and expertise.
Yeah, they have firsthand experience for so long with it. That's definitely true.
Yeah.
So what would you say are some misconceptions people would have or practitioners would have about metabolic therapies and repurposed medications?
Misconceptions, yeah, is efficacy. They just don't know what you're talking about. Like, if you say metformin for cancer, they're just like, that's a diabetes drug. They just haven't. And to their in their defense, there's it's insane the amount of information out there that doctors would have to ingest to be experts in everything. There's just too much. Um, but it's like any scientific sort of sea change. It's happening, but it happens at a glacial pace. I know there's most doctors now probably have heard about the ketogenic diet and cancer, and it's changing, but it just takes so long. It's frustratingly slow. In that meantime, I'm sympathetic for the people that have cancer and are struggling to find, people that at least they get the validation that they're not crazy, that what they're doing could potentially help. When a doctor says, don't even bother, it's not going to do anything, that puts them in a tough spot, and it's not true. It's not true. So yeah, it's just time. We just have to be patient.
Yeah, and I think, like we said before, with all the emerging information and data coming, hopefully we'll be seeing tides changing abroad, especially at the bigger institutes. I live here in Houston. I see some oncologists at MDA are willing, to implement this, while others not so much. Thank you for sharing your valuable insights and empowering, everyone that's tuning in today with your knowledge about metabolic therapies and repurposed drugs, and being on the forefront of some clinical research that will now be emerging. It's truly been enlightening and delightful to connect.
Thanks for having me, and thank you to what you guys are doing. Heal Navigators is a wonderful platform. You guys are doing wonderful work.
Thank you. If you're interested in learning more about how metabolic therapies can be integrated into your cancer treatment plan, we encourage you to check out Heal Navigator's Cancer Metabolic Optimization Program. Our program offers personalized support, includes blood work analysis, consultations with expert oncologists, and ongoing guidance from our team of integrative oncology nurses. You can find more information on our website.
Thanks for joining another episode of the Heal Navigator podcast. Remember, you're not alone. At Heal Navigator, we're dedicated to empowering you with the knowledge and resources to navigate cancer care. If you'd like to learn more about integrative cancer clinics, explore the alternative treatments we offer, or speak with one of our experienced patient care advocates, please visit our website. We'll drop the links in the show notes below. Until next time, take care and keep exploring your options.